Hi, good afternoon. As she said, my name is James McGee. I'm a parishioner here, been a parishioner here for a long time. I have 5 kids, 4 of them have gone through. I have 1 left here in 7th grade. So my wife and I are pretty much involved in a lot of the school side of it. I also want to give some time here on the parish side as well. My wife and I, our topic is palliative care and hospice care, but I want to kind of talk a little bit about what leads up to it, which is a lot of times you start off with assisted living, and that's kind of what my wife and I have been doing for years. We have assisted living business, and it's not here to promote our business or anything. It's just to give our experience in what we've been doing for the last about 15 years. Assisted living basically is a term that's been used over the, basically it's a new concept for the last 25 years. It's the fastest growing long-term option for seniors. Assisted living facilities with their wide range of services provide a senior housing solution for adults who can live independently but also require some assistance. For many seniors, assisted living provides just the level of care they need to flourish and triumph in their new phase of life. After all, the golden years should be enjoyable, and assisted living has more options than ever before. A lot of the stuff that I have that I'm going to be reading off this paper is just straight from the website. You Google assisted living, hospice, palliative care. It's a ton of information that will come up. And I just want to give you some basic knowledge of assisted living, and then we'll transition into palliative care and hospice care. And we also have a hospice company, my wife and I, that we started about a year ago, so we're now providing hospice care as well. So we have a lot of knowledge in that. And the hospice care kind of, again, it goes back to assisted living. We have what we call residential care for the elderly. It's residential assisted living, and the difference is you have a regular house in a regular neighborhood, you're licensed through the state, and there's tons of us out there. A lot of people don't know that we exist until the time comes, and obviously that's why you guys are all here to kind of educate yourselves on when assisted living is needed, when palliative care is needed, when hospice care is needed. So again, you have your residential care assisted living, and then you have your large facilities. The large facilities like the Grand Regency here, Atria, all the local larger assisted living places that you may or may not be aware of. We're basically the same. The assisted living, you have people in there that are independent. In our residential care facilities, you have people that are independent, as well as the large places. Then you have people that need minimal care, and you have people that need a lot of care and that are bedridden, and everything in between. So you have some residents that may have some mild dementia, mild Alzheimer's. They get to a point where their loved ones can't really take care of them anymore, and so they need to go into assisted living. And a lot of times it's difficult to make that decision because you want to try to stay at home. Everybody wants to stay at home. That's a goal I guess probably everybody would want, but at some point in life, sometimes things take a turn, and the caregivers can't care for them anymore, they're working or whatnot, and they have to go into assisted living. But assisted living, again, depending on their level, I tell people all the time that the larger places are great for people that can enjoy all the amenities that the larger places have. Some of them are beautiful, they're hotel-like, they have all the different activities and things. But those that need a little more care, I favor and push towards the residential care because there's a little bit, it's basically 2 caregivers to 6 residents in each of the residential care, where in the larger places it's more 1 to 15, 1 to 12, just depending on each place has different criteria. So some of the basic services offered in assisted living is 24-hour supervision and security. And the supervision and security is mainly for those that, dementia, Alzheimer's, that wander. And I don't want to call them escape risks, but in a sense, they wander and they walk out the facility. And I'll let all you guys know, my regular job is law enforcement, and I got into that 24 years ago. I used to work patrol, and it would be at least 3 or 4 times a week I would get a call for somebody that wandered out of, whether it be their home or assisted living or a hospital or whatever. They'd be calling us to try to coordinate to find the person. And you guys see it on the news all the time, where people wander away and they wind up 2 counties away in other states. And unfortunately, that's Alzheimer's and dementia, and that's just what it does. So the 24-hour supervision and security, that's kind of for for that type of and then security as well. I mean, they're secure in there. I mean, you can't just walk into these places, including the residential care homes. They're all locked and things like that. They provide the daily meals, basic housekeeping, laundry, health and exercise programs, social programs, transportation, access to medical services, a lot of the everything that you would need in life. Some people can use them and some can't. We have in our residential care homes, we have some that still take dial-a-ride and things like that. We also have we provide transportation, as well as the larger places provide transportation as well. You see the buses and stuff. A lot of them come here to church. The Atria van that brings a lot of residents here to church and stuff. These are just basic facts about assisted living. The number of U.S. assisted living communities in the U.S. are 31,100. Number of assisted living apartments, 500,000. The number of residents are 750,000. 735,000 people in the United States live in assisted living facilities. And the average length of stay is about 36 months. And percentage of residents that receive help with the average or activities of daily living is 40%. These are just numbers from the Center for Assisted Living. Again, if you Google that, it'll give you all these facts that I'm giving you. And signs that your loved one may need assisted living. We covered wandering, the sundowning, and I'm not sure if people are familiar with sundowning syndrome. is a common term in assisted living and skilled nursing homes. It's a very agitated behavior that becomes more pronounced later in the day. Is a common characteristic of those with Alzheimer's. It can take a heavy toll on caregivers, and when it begins, it severely disrupts family routines. And this may be a time that you might want to look into assisted living. Aggression, if a person becomes aggressive. Home safety issues, that's one of the big ones. You'll start noticing where they may just turn on something to cook and they're really not cooking anything. They may put a pan on there, turn the oven on, and you'll have a burning pan. That's very common. They start drinking things that aren't normally drank by us. They'll pick up a bottle of Listerine and start drinking it rather than gargling with it. So they start forgetting, and again, this is all stuff that's dementia and Alzheimer's that mainly do these type of things, but these are the reasons to think about assisted living if that starts happening. Escalating care needs, obviously, if the person's starting to need more than we can provide as a family. We currently have my father-in-law in our home. He's got Alzheimer's, and it just happened recently where one day he tried to go home and he couldn't figure out how to get home, and the next day he got home and then he had a couple more episodes. We took the car, and those are some hard things that you have to do in life, and some of you may have already done it, and to take someone's driver's license and keys away from their car is very difficult. It takes their independence away, and it's something that's really difficult. But right now he's still very functional, so it's kind of one of those things that we're still able to take care of him. It's not, and we have the 5 kids still, and a couple of them are older, but it definitely disrupts the house, and it's hard to do, but it's something that obviously, again, we want to try to do to keep someone in their home as long as possible. I mean, that's just, I think everybody wants that. And caregiver stress, one of the biggest things that we find is, and why we're in existence along with all the other assisted living, is because a caregiver can no longer take care of the person, whether it be physically or just mentally. It's draining on the person. And unfortunately, we've had this happen so many times in our homes where a husband and wife will move in, and the husband still take care of the wife, or vice versa, and the person that is not sick passes just suddenly for different reasons, because the stress is so overbearing on the other person. And again, this is kind of like a depressing type of a topic, but I'm not trying to depress or anything. I'm just trying to educate everybody on the things to look for. It's reality, exactly. Yeah, that's exactly what it is. And I tell people, one of the biggest things, and a lot of families will call and thank us because once they make that decision, it's time to put somebody in one of the homes, assisted living or larger facility, they're relieved. Now they're able to come and visit and not worry about showering the person, giving them medications and all the different things that are involved in taking care of a person that's sick. So a lot of times, once that tough decision is made, they're relieved, and it makes their life and everybody's life a lot easier. Let me see what else I have. And that kind of like transitions into the hospice and the palliative care. A lot of times our residents, and again, the average stay in assisted living is 36 months, and a lot of times it's not because they move out, it's because they end up passing. And so that kind of like goes into our palliative care and hospice. As time progresses, the person, Alzheimer's disease, Parkinson's, I mean, you name it, congestive heart failure, all the different things that are reasons that people deteriorate and get sick, is where the palliative care and hospice care comes in, and that's where I'm going to bring Henry up to talk about that. But before I does anybody have any questions on assisted living? I can answer questions about hospice as well after he makes his presentation, but right now I'll just focus on the assisted living part of it. You have a question?
Is assisted living similar to board and care?
Well, yes. I mean, the residential care for the elderly in our industry is board and cares. The hospitals refer to us as board and care. So you'll hear a lot of larger facilities say, "Oh, you're gonna, board and cares are another option," and that's the homes in the residential areas. You'll drive by our houses and you won't see that we're there because we can't put signs up. It's a city ordinance thing. Once you come over 6 residents, 7, 8, 9, you become commercial, and therefore you have to have the different licensing criteria. But that's basically, yeah, board and care and is the same thing as residential care. Yes?
Do insurances cover?
That's one topic I forgot to cover, and I will cover that. Unfortunately,
cover that explicitly. We can have another meeting for that because that's what we do for a living.
Okay, great. No, in a nutshell, insurance companies do not cover assisted living. They do cover skilled nursing. So if somebody falls and breaks a hip, for example, or breaks a bone, they'll go into the hospital. They'll stay there for a week or whatever it takes to get them into a rehab center, the skilled nursing facilities. They'll stay there for a short time. The insurance companies pick all that up. But once they go home or go to an assisted living, because a lot of times if an elderly person do break their hip or whatnot, they can't stay by themselves anymore. And the doctors a lot of times will tell them, the families, hey, you know what, it's time that they need 24-hour care. So they don't cover that, unfortunately, unless you have long-term care insurance, which I'm sure is something that is very beneficial. We have some residents that have it, but it's very few and far between that actually have the long-term care insurance. There's also veterans assistance that covers assisted living. If a person was a veteran back in one of the wars, or I'm not sure all the criteria on that, but I have resources if anybody needs it. I can.
I have them in the car if you want. I mean, I do that all the time.
That's perfect.
Spouses are really more impacted, especially if the guy dies, because the spouses usually outlive the veteran in those eras.
Yes.
And they can get a benefit like that, but only at 50%.
Yes. There's a whole bunch of different places out there that will help with whether you qualify for the veterans benefits. So your basic cost for assisted living, again, this is educational reasons, is you can find a assisted living place for $2,000 upwards of $20,000 a month, depending on where you want to preside. They have some really nice places on the beach with ocean views, $15,000 a month. I'm serious. It amazes me the amount of money people pay for some of these places. And the average, you're looking about $3,000 a month for a shared room, upwards of $5,000 to $6,000 for a private room. Now again, most of the time it's going to include all your meals, all your care, all your basic soaps and toothpaste and things like that. And so if you look at the $3,000 shared room, it's $36,000 a month. It's still a lot of money, but in the grand scheme of things with the care and everything, it's not so bad, but it is expensive because insurances don't pay. And a lot of people, that's one of the biggest issues that I get all day long with families that their loved one only gets, $1,600 a month Social Security. What do I do? And fortunately, there is Medi-Cal out there and other programs that are available, but again, sometimes those places aren't as nice as the ones that you want to put your loved one in, but unfortunately, at the end of the day, money drives everything in our world. And so that is what it is. But that's a great question. That's a great question about finances, because they don't. But there are options. The long-term care insurance is a good option. It is a little expensive, and you just got to be careful on the policies. And he'll explain to them, because some of them will cover for a certain amount of time. They'll only cover 20 beds or more, and so residential care doesn't come into play. Now, most of them were written a long time ago. A lot of them are new, and they're changed policies and stuff like that. Yes, sir.
I have a question. I want to address a question to you. Didn't the Catholic Archdiocese and all the deaneries have a facility, or let's say you've been a long-term parishioner of whatever church, and you're a lady or a guy, and you can go there and retire? Aren't there facilities like that?
Now, some of the religious orders,
Yeah.
like the Carmelites started that,
Right.
but that strictly was a takeoff. The only thing I know about is that Carmelites in Alhambra opened the place.
Right.
But that had nothing to do with being a parishioner or anything like that. The Archdiocese sponsors that.
Okay, all right. I just wasn't sure that.
The Archdiocese.
Oh, no, you better believe it. Yeah.
Yeah, it's really expensive, unfortunately. I mean, and it's being more and more governed by the state. They're putting so many more restrictions on our industry, from mandating different insurances and the amount of coverage and things like that. The 24-hour care, again, these people get paid. The caregivers that live there get paid 24 hours as well. So there's a lot of it's expensive. So that's why the care is so much. And we're seeing it just grow and grow, and now minimum wage is climbing. So most of the jobs for the basic caregivers, $10 to $12, $13 an hour, now they're jumping to $15. So all it's going to do for everybody out there, unfortunately, is bump everybody's costs. And I don't want to get political, but unfortunately no, I'm not going to do that. But it is. Unfortunately, everything, everybody raises things, and it just it trickles down to all of us, unfortunately.
Right.
Yeah. Yes?
I was just finding that right to die, that legislation that I think it was taking effect in January.
Yes, me and
Makes it all cheaper for the state or something, right?
me and Henry were just talking about that. We were just talking about that, and that's going to be another one of those. With our hospice program, we're already taking the stance that we're not going to provide that medication to any of our patients. The hospice program, and he'll explain it better, is to make somebody comfortable at the end of life, but not to take God's hand in it. And it's when He says you're going to take your last breath, that's when you're going to take your last breath. We're not going to provide that medication. Now, it'll be interesting to see how the government and everything makes the different industries, if they're going to make us as part of our hospice, because we are paid through Medicare. Hospice is a free program. If they're going to actually make us provide that. So that'll be interesting to see. Again, it's going to just take probably years before somebody fights it, and it goes up to the Supreme Court and stuff.
On the larger picture, one of the reasons why Moonbeam and Talking Politics and the Democratic Party all voted for finally your life choices, leave it at that, is that sadly, and I mean this sadly, the Medi-Cal budget, especially on the long-term care side, is already almost at 14% of California's budget. Okay, and you look at the size of this state, of the budget it generates, plus education, parks, roads, all the other bureaus, and you see the Medi-Cal budget, which is approaching 20%, okay, which is hundreds of millions of dollars. People are going to live a long time under Medi-Cal, so the state, it was an economic decision. We can't warehouse people like this. We just can't.
Right.
We just don't have the funds for it. So something has to be done, and sadly, it's an economic decision instead of a spiritual one.
Right. And we are living longer, and obviously every website you go to, every year our lives are extended by medication and all the different technology and stuff, which is a good thing in a sense, but again, it's very financially burdensome on the state, families. Families a lot of times, again, when they come to our homes or any other places, they're supplementing their moms or dads or brothers, sisters, whoever it might be. They're supplementing, and so they're struggling themselves, yet they're trying to pay for mom and dad's care. So again, it's one of those. It's a tough industry. It's a tough for the government even to try to figure out it's tough. So, yes.
Just a general question, like I've met people who are non-funded, they are admitted in a hospital, like for traumas, they might be homeless, and then after acute care, I've heard social workers saying patient will be sent to a board and care or assisted living. So I'm just wondering who is funding them?
Medi-Cal. Medi-Cal is the only one that funds that program, and otherwise they end up in a hospital, or the hospitals want to get their patients out as quickly as possible, along with the skilled nursing. You get 100 days of skilled nursing per year, and then sometimes if you're not peaking, they'll get you out a lot faster. So a lot of times Medi-Cal will pick up not a lot of times, they'll pick up the tab for the ones that can't afford it. And you have to qualify for Medi-Cal. There's a lot of criteria that you have to meet in order to qualify for Medi-Cal. So if you have a person that owns a house, and it's your mom, let's say, and you try to sell it one day to say, oh, she's got no money and she's going to qualify, that doesn't work. So there's a lot of different things you have to look at for the Medi-Cal program, but and that's very complicated. I don't really deal with that stuff, but Medi-Cal is the one that pays for that type of care for those that can't afford it. And a lot of times the Medi-Cal facilities, again, are larger, more quantity than quality, but unfortunately, it is what it is. Does anybody else have any questions? All right, I'll bring up Henry, and we'll...
Good afternoon, everybody. Again, my name is Henry. I'm a registered nurse here. I've been licensed in the state of California for 14 years, and I'm also a Catholic. You know, I sing in the choir every Sunday. My children's actively at 3 o'clock. I gotta go. He's in the they're in the children choir too, and I'm in the 5:30 choir in Holy Family in Artesia. So thank you for the opportunity to be able to speak about hospice and palliative, because there's not many resources out there that educate the community, the differences, what's available for us. And then when the time comes with our loved one and we got the news, it'll be too late. And we all scattering around and what's out there, and we don't know. And that's how a lot of the family get trapped. They don't understand, they don't see it. They don't, they didn't think that it's gonna happen to them, right? So that's why I love, out of 14 years that I've been a registered nurse, I love hospice the most, because you know what? I see where life is more respected. We're not doing things out of one's will. We're here to support families and patients, what they want with their life. How many of us go into the doctor and say, okay, cut down your salt, cut down your fat? Say, it's hard, because who are we to tell, people to live? Okay, again, there's a lot of misunderstanding or misconcept about hospice. Okay, and this, we're not here to be trained to speed up life. We're here to provide quality and care for the remainder of life. That's what hospice is. The difference between palliative and hospice, palliative, you still qualify for advanced medical treatments, but in hospice, you're just, living your day-to-day back to, your natures. Let natures take its course whenever, the good Lord takes us. And it involves a lot of symptoms management. So there are different, level of care depending on the patient needs. Okay, and then we work hand in hand with the boarding care caregivers. We educate a lot of, the boarding care and the families about how to manage their symptoms. Okay, so it's a lot of symptom management, technically. And the goal of hospice is just, just maintaining comfort, maintaining that dignity, dignified life till the remainder of, of one's life. How many of us, let's say, get tired of going to the doctors, or it becomes very tasking for them to even get out of the house. So that's when you start looking into what are your, your priority. What is it you want? And when you go to the hospital nowadays, because of the changes in healthcare industries, you know what, the days that we stay in the hospital is shorter and shorter. And you see how many times you go to emergency room, they're gonna say, oh, UTI and dehydration. Why? Because that's the most common thing, because they don't know. They don't know how to heal you anymore. They don't have the budget to heal you anymore. That's what it is. It's all managed through, you know, politicians again. You know, it's, the budgets are so short, and, you know, and we as a community and as the consumer, we're just not knowledgeable enough with what we have. Okay, and then they send you guys home. Guess what? 2-3 days later, your symptoms come back, and you got to go back again. It's not like before. When you go to the hospital, they treat you as a whole person, whatever that you have. Now, no. They're just treating you what you're coming in with your complaint, and they send you out. And then if you meet the criteria, there's no more, and you know, it becomes very tasking for you, and they see it in the family, it's hard for them to go to the emergency room, then they're gonna talk to you about hospice. Okay? Yes, the criteria of hospice should be 6 months or less, and it has a terminal condition, but it's the Medicare benefits, because we are funded through Medicare. Okay, if you have private insurances, they all go back to Medicare. So if you have Kaiser, you have Secure Right or healthcare, it's going to go back to Medicare, because where the fund is, it's on the Part A Medicare, which is the hospital part. Okay, so that's why a lot of the shifting of the healthcare is going to be community based. And that's where palliative, they call it palliative, because they still go to a facility to seek that, sometimes they still have an outpatient chemotherapy, they can go into palliative. But in hospice, we're just staying home, managing at home. We're not going anywhere. We're just, where we're comfortable. Okay? Because we don't have to go back to the hospital where, strangers coming in at 4 o'clock in the morning drawing your blood anymore. That's not going to happen, because it's not going anywhere. Okay? And then when we're at home, we try to support the family too, educate them. Okay? And have them understand what grieving, something, not only the patient, we're working with the family through their grievance, to get through their grievance. And hospice doesn't end until the patient passing. No. We have 6 months follow-up, 3 months, 6 months, 1 year that we have bereavement program. But it's, so it involves nurses, spiritual counselors, social workers, doctors, even your doctors. That you don't have to go to your doctor anymore. We have our hospice doctor that comes in. Question?
Yeah, question, and please correct me if I'm wrong. Theoretically, isn't the hospice your last hurrah, so to speak, in that, let's say you've got a time frame of about 10 months, and let's say I've got terminal cancer. I look like Swiss cheese. I'm hanging around for 6 months. I'll be at a hospice until the last hurrah, basically.
Through my career, I have a few percentage that graduated through hospice, because we don't know. We don't know what God tells us until we just don't know. I have a patient that really, I thought he'll last 3 days through my knowledge, through my training. But you know what? Who am I to say that? Who am I? It's up to him.
Sure, of course.
Well, I heard that in hospice, you can't feed, because their organs, some of them are, their organs.
They're failing. Uh-huh.
And I've heard that they're not supposed to give many food, maybe just water.
That's the general idea of understanding, but that's not the whole case. How many of us go into emergency room because of dehydration and they push you fluid? 2 liters of bag and within an hour, right? Okay, think of it this way. If I go to your house and make you drink the jug of water, would you like that?
No,
No, right? And what's your favorite food?
anything.
Anything? Chocolate?
Just food like Chinese food.
Chinese food, okay. You have a simple common cold and cough and sore throat. I'm gonna come in and visit you at home with a bucket of Chinese food. Would you want that? See, the daily necessity of an individual in hospice, okay, becomes a task. When you see that, okay, it's not us starving them to death. That's what a lot of the idea is. Yes, we starve them to death. No, it's their disease process that's prohibiting them to do what is necessity for living. Okay? If I'm coming in and give you a bottle of water and make you drink that, you're not gonna like it. See, that's how it is. That's how we're going back to a simplicity of living. Okay? I know a lady, in common general patients, the last thing that they need is just being satisfied, being recognized. They just need us to be there, being compassionate with them. They may not be able to swallow or drink. They stop the artificial feeding because why? I've seen a patient that we push, artificial feeding, but guess what? It's just come out right away. So that creates more struggle for the body to sustain a life. And when we get to that point, then we have to make that decision. And we're not just making a decision, we always have to talk to the family member. Let them realize, this is what we do. What do you think? I myself as a nurse, I involve a lot of the family members in all the decision, not just the healthcare. Every 2 weeks we meet, we have the team, the social workers, spiritual, we all meet every 2 weeks and talk about our patients. And then when we go to the house, we involve the family in that plan of care so that the family has, they have clear conscience in their decision. Because that's important for them because, the patient their life is just end when it ends. But then the family, sometimes they struggle because they get to go on with some of them have the guilt of their decision, right? So that's why it's important to involve yourself with the supportive care, just like hospice or palliative, because it empowers you in your decision making. Okay? Any questions? Yes, ma'am.
I know in some cases, patient that will be placed under hospice care, I've seen that it takes a while to make a final decision because it's good if there's only one family who is a decision maker.
Mm-hmm.
But if there's a lot of family members, it ended up fighting against each other, and probably sometimes if they all agree, the patient disagree.
Right.
There's a lot of problems that will be encountered in the process of placing the patient under hospice care.
Right. The issue's there. We have to remind everybody that this is not their life. How many of us make decisions because of how we want to do things?
Yes.
Right? So in that term, you have to go back. I sat down with 13 children, of my patient. And again, I remind them, this is not their life. It's their dad or their mom. You got to think for them. You got to put your ego away to understand. And the one that really have issues are the one that's having problem letting go. Because you know what? We're all selfish. I am. We all do. We can't, and you know what? How we love for our parents are different. How you love your mom and dad and how your sister love your mom and dad, they're different. But again, you got to remind yourself, you got to set aside yourself and think for your mom and dad or whoever the patient is. What do they really?
I'll say that's a common issue with assisted living to hospice is you have a lot of different opinions. you're different than me, your brother's different than you, whatever. And it's very common for there to be disagreements, and usually it comes down to the person who's actually the power of attorney.
Right.
Who's the actual decision maker. It's only going to be usually, if somebody has an advanced care directive, it's usually going to be one of the people that mom or dad or brother or sister appointed. So if they appointed me, I'm the final decision maker. No matter what my brothers and sisters say, I'm going to make the final decision. A lot of times it's not popular. It may not be a popular decision because I'm disagreeing with my brothers and sisters, but my dad decided that I'm going to be the person to make his decisions, and then a lot of times it comes down to it. A lot of times people don't have that will as well to make that decision, and they'll go with the group decision. But a common misnomer with hospice is that we starve them and this and that. It's not like that at all.
It's not.
Hospice is simply you're gonna, if you have cancer, you're going to stop chemotherapy. That's it. But you're going to go about your daily business. But the doctor is going to tell you, if you stop your chemo, you have less than 6 months to live. That's where hospice comes in. And you're going to eat every day and drink and go to the bathroom, shower, until a point comes where you can't do it anymore. Hospice is like an extra service. It's people that come and help you bathe, and nurses and doctors that come to your home. So it's a common misnomer that's what happens. And again, it's just, unfortunately, hospice is
There's so many misconceptions out there, misinterpretation out there. Yes, sir.
Yeah, I have a question, more philosophically than anything else.
Mm-hmm.
What percentage of people actually want to go to a hospice and pass away? Because let's say that one of these ladies here in front of me here all had a lot of children, so children get involved. But let's suppose they didn't have any children. Let's just suppose a lady or a guy didn't have any kids, one guy, one person. What percentage of that proportionally? It's okay, I'm done. Check me out. The canteen is closed. Boom.
The percentage is very slim because you know why?
No, I don't.
Because no one wants to hear that they are dying. Right? Nobody wants to hear that. But again, when you realize it yourself, when you come to peace yourself, okay, that there's no good of going to the hospital. It's just you will know yourself in the end in your heart that you know it's time. We can't make you. I can only tell you what is available for you. But in the end, the decision is up to you. Okay? And again, don't believe those big HMOs, Kaiser, they have their own hospices and then they'll qualify it, right? I'm not saying bad thing about Kaiser, I'm just but what I'm saying, but again, it is the right of an individual and a family where they want to be in their life. If you still want to go and fight and go to the hospital and get your chemo and be able to sustain a quality life, by all means, don't stop, because miracles do occur.
We see families all day long that they want to call 911 until the day they pass.
Yeah.
They never go on hospice services, and that's fine too. Hospice services are just an extra hand to help the families, and but there are a lot of people, usually younger people that want to fight their cancer or their illness till the very end, and the families refuse to accept hospice and accept passing at home. And then there's a lot of different nationalities and religions and stuff that they can't, their loved ones can't pass at home.
But
They have to pass somewhere else.
But yes, it could be, in California, it could be a cultural, religious, and ethnicity, something they have practices. And hospices, we do respect those practices too. When we come home, I had a patient that wanted to go home. Hospice don't provide ventilator anymore because that's a life prolonging measures. Okay. And there is, it's hard to run a ventilator at home because, it takes a lot of education to the family, and they ended up being very burdensome with the task. So what we do, because of their cultural, they want to pass at home. So if we know that they're not going to make it in the transport, we'll try to accommodate that. That's what hospice is. Okay.
Let's say I'm trying to say this nicely, our arch enemies, the JWs, and the guy doesn't want to die at home, but religiously he's a JW. That's a Jehovah's Witness for everybody else. Mm-hmm. But they don't want to die at home, okay? And the guy's told my religion prohibits it. Okay?
Right.
Now what do you do?
Well, again, we respect their decision because you know what? I can't really touch anybody without a consent, you know? And if we provide them enough tools and they seem like because of their religion or whatever cultural background they're coming from, it feels like they need to be in a hospital setting, then, you know, we have to respect that. Yeah. And again, with hospice, there are a lot of advantages. You know, if you realize that you yourself, it becomes very overwhelming to go and seek, you know, intervention, then you know what? Why not live your life at home where you're more comfortable? Okay? We bring the discipline, you know, we even have volunteers that sings. You know, if you like gospel music, they come in and with their guitars. We have, you know, hospice do that too. You know, so it's like, you know, no one tells you what to do at 4 o'clock in the morning. You gotta wake up, you gotta draw your blood. You know, and it's just enough is enough. That's what hospice is. But if you think that you still have the power and that you think that it's still beneficial for you, by all means, it is your right. Okay, and hospice is, again, it's going back. It's funded through Medicare, so it attaches with the hospital benefits on a Part A. Okay, so a lot of the community, they misunderstand too. So they can be in hospice and they could go to the hospital. Yes, at some point. Let's say you're diagnosed with the heart failure, okay, and you're admitted to hospice because of your heart failure because there's no more treatment and you're not seeking any more treatment. But when you're active at home, let's say you fell and broke an arm, you could still go to emergency room and to the hospital and get treated for your other things. You could still go to a podiatry and get your toenail trim, you know, go to your eye doctor, your ear doctors. So it's like hospice is supplemental care, okay, pertinent to your whatever, you know, illness that you have, okay? So it's not just limited, you know, you can't go anywhere after you're in hospice. No. That's why I see some patient, you know, they're graduated from hospice, they go back to rehab. Yeah, because we don't know. Who are we to determine, you know, your way of living? But we're here to provide you the dignified care to support you till whenever time comes.
Another thing that people don't realize about hospice too is if you're on hospice, and let's say you're on it for a month or so, and you decide, you know what, I want to go back to chemo. I want to get chemo again. You just quit hospice and you go back to chemo. So there's nothing holding you to hospice. It's just, again, a supplement to your primary diagnosis. So if you decide one day I want to be off of it, you're off of it. Or if you decide one day I'm the family, call 911, I want to go to the hospital. That's exactly what we do. We call 911, you go to the hospital, and the hospice benefits stop temporarily or permanently until you decide to go back on. So there's a lot of different options, and most doctors are pretty familiar with hospice, but a lot of times they're not familiar with the diagnosis. Medicare is very strict now on how you qualify for hospice because a lot of companies have taken advantage of it in the past, and people will be on hospice for 2-3 years, and it's not uncommon for people to be on hospice for 3 or 4 months, and all of a sudden they're perking back up, everything's looking good.
Yes.
They go off hospice for a month or two, and then they start deteriorating. So it's not uncommon to go on, go off. You know, so it's a misnomer. A lot of people think hospice is end, that's it. It's not that simple.
Yeah, because Medicare benefits tells you the first two episodes will be 90 days, and then after that, the third episode, fourth episode, and so on, they're unlimited 60 days. Okay, but the thing is, we are restricted by that Medicare. You know, as an agency, they look at us by percentage. How many of your population, of your patient that you care for, are passing the whole 6 months? They look at it that way, and that's how they grade us as an agency. Because a lot of agencies out there, Medicares are getting smarter and smarter. Because a lot of agencies out there, they just pick, oh yeah, you can be hospice, everybody's going to be hospice. But guess what? They keep them forever. Do you think Medicare has ways to monitor that? Because what we as a hospice agency, we're just managing your benefits. Your hospital benefits as part of Medicare, it entrusted us to help you guys with your day-to-day thing, including your medication, your diapers, nurses, social workers. Those are part of it. Okay, we have your medication delivered to the house. Okay, and a lot of people here, there's misconception when it comes to medication. Oh yeah, when you're in hospice, they force you to stop your medications. Right? There's a lot of misinterpretation on that.
That's not true.
That's not true. I myself, I don't want, but the thing is, if I see my patient are struggling to swallow a big old pills, a horse pills, you know, and they're already hard as it is to swallow their own food, why would you want to force them, especially on the vitamins, right? I mean, it's good when you take vitamins when you're young, but when you're 90, 80, 90, you know, you're having hard time to just doing your essential daily living, you know, and take away that additional stressors. And we involve the family on doing that. We're not just, you know, hey, you got to stop this. No, it's not my, you know, it's not my, what do you call it, my practice to just, you know, take over your life and manage it. No, we want to give you, well, how are you taking your pills? Are you okay? Oh, they're bad taste and I don't want it anymore. A lot of them, they said, okay, then let's prioritize what you want to take. Let's make your life easier. The one that it's good, you know, the one that's still working for you, then go on, take it. Right? And we concentrate about, again, it's symptom management. If your symptoms are not being managed, the nurses will come to the house and talk to the caregiver and support all the families, make sure that your symptoms, and we have licensed nurses that will stay 24 hours until your symptoms managed too. Okay, but it has to be justifiable because, again, Medicare is very strict now with their rules, you know, and guidelines. You know, there are criterias that we have to, you know, to include and, you know, assess on the patient. Okay. And then we also help, you know, in our company, I'm not trying to market our company, but we try to be a one-stop shop, you know, because I have networked that a lady who is a state volunteer, they'll do advanced directives, because how many of us, you know, we can't pay lawyers to just develop advanced directive and living will, living trust, you know, and I have a lady that does that. Okay. So it's, you know, it's a lot of benefits, you know, a lot of supportive, you know, the correct practice of hospice, it's supporting your needs wherever you at in your, you know, life. You know, the doctors could say, yeah, you have 6 months, but then, you know, I had a lady that, you know, maybe a month more. We don't know. Okay, and a lot of the family, they said, well, how long does my mom have? We don't know. 6 months or less, that's what the guideline says. Any questions? So the different, again, palliative and hospice. Palliative, you still be able to seek that treatment, going to an outpatient chemo, go to the infusion center. Okay, even some people they can go to dialysis while they're in hospice. Okay, because that's what, you know, it depends on your diagnosis. So let's say if I come into your house and you wanted dialysis done, then we have to look your other terminal condition. Okay, and you could still sustain that.
Have you ever had anybody in your experience, let's say traditional medicine, not so much cancer, but some other illness that puts this individual in a hospice situation, say, you know, I want to try some alternative medicines, okay?
Yes.
I want to do herbs, and I want to do
Yes.
Singing and dancing, and get the witch doctor in, and all this kind of stuff.
I had a guy recently, a 52-year-old with multiple sclerosis, and he was in bad shape. He was, you know, I thought.
Did he have a pot card?
Yeah.
Marijuana card?
Yeah.
Mary Jane card?
Yeah. Yeah, and somehow, you know what? He graduated last week because he got up. We managed his pain, and guess what? he sees a different, you know, when you're in pain, when we all in pain, guess what? We're going, oh, just take my life, please, you know? That's how we felt, right? So then, but then when we come in with our expertise and manage your pain, and our doctors are really good at pain management, guess what? Oh my God, I see a different me. I could get up now, and it motivate you. And last week alone, he was very thankful, and he's back to our home health and getting a physical therapy. See, it's just, you know, that's what the amazing part of hospice care, because you know what, it makes different in one's life, because we don't know, you know, and I'm not, you know, when I graduated nursing, I didn't take a vow to speed anybody's life, and I'm a Catholic, I'm pro-life. I do the marching in downtown LA for pro-life last year, you know, this year in January. See, but you know what, now that the new legislature's, you know, passing, that's gonna put a lot of stress too, because, you know, a lot of the family, they have that control. It's really, you know, we want to empower them. We want to educate them what is right. See, but it seems like the more money you have, the family members, they can't get along, and somehow they forget this patient, and, you know, they just want speed things up. They keep asking, you know, their first question when they see me, how long, when? I was like, come on, he's your dad, you know? I was like, yeah. That's reality, I'm sorry, you know, I'm not trying to, you know, but that's, somehow I have families, 2 sons, only 2 sons, owns 3 McDonald's franchises. They couldn't be in the same room without their lawyer present.
Splits families.
Yes. And it's amazing.
See,
Yes, sir.
It seems to me with the directive that was passed by Moonbeam and the Democratic Party, it just seems that instead of having a doctor or some other licensed professional make a decision about somebody's life, I mean, it's life or death now, it just seems they're pushing it downstream to let's say an individual like yourself or
Right.
family. Okay, let's pull the plug like a Terry Schiavo. You have to wait 15 years now.
Yeah.
Do it right now. Instead of having the appropriate people make decisions, you're kind of diverting that to have somebody else make a decision. I just think it's just bad.
See, it's politician derivative care.
Yeah, sure is.
Now, that's what it is. Even with, you know, it's very important that one homework that I can tell you guys tonight, look into your benefits, what you have, okay? Be ready. What are you guys available for you? Okay, if you're with SCAN or something, you know, you gotta look at, because those managed care, you know, I look at it by, my example is muffins. You come in with a dozen of muffin. Medicare, that's their budget. Everybody that qualifies for Medicare, they have 12 muffins a year. And they sign up with Medicare. Yeah, they give you free transport. They give you this. They take away out of that 12 muffins. And then, you know what? When you need the other 10, wait a minute. I gotta wait. We gotta go through the case manager. We gotta wait for the authorization. And when I was in the emergency room, we have a patient bleeding, and we go, so we should wait? I was like, what are we gonna do? Well, try to contain the bleeding until we get an authorization. I was like, yeah, right. And that's how it's been. And you know what? It's not getting any better. I'm sorry to say that. And that's why, you know what? I see hospice as a better and suitable for me, because you know what? I see that there's more compassion, there's more dignity in a person than in the hospital. Because when you're in the hospital, you're not given any choice. And you're not, when you're in the hospital, you're there for 5 days, guess what? You probably see 5 minutes for your doctor. Right? And then you probably come in when you're asleep. Right? See, no one talked to you, what's going on? And all of a sudden, all you know, hey, you gotta go home now. Well, we don't have anybody. Well, too bad, we need the bed. You know, that's how it goes nowadays. And it's sad. And that's where I see the shifting is more community-based. It's more of a private instead of, being in a hospital settings. Okay?
Somebody asked, you think it's because this changes is because of Obamacare? A lot of it has something to do with it.
I should, well, how am I going to say this? There you go. It's a great idea. I think it's a great idea, but then you know what? I don't know if we could afford it.
At the end of the day, they're trying to manage, however many millions of people there are in the country. And I don't think there's any right answer to the medical problems that we have and the insurance companies and all that. It's just it's a tough subject. I mean, I don't think there's any right
7
answer.
co-ops have gone broke already, one of them broke Friday, and one insurance company's going down the toilet. So here they come.
Yeah.
It's a tough one.
See, so to end this, I read this from you guys about the next step in care. Again, in hospice, I see more biblical care versus spiritual care versus in a hospital setting, because, the dignity of human life flows from creation in the image of God. So that's what I always, I live that. When I see my patient, it's really up to you. Well, I've been drinking all my life, and you know what? My doctor told me my kidneys, my liver's shut. I say, I want my vodka back. If that's what makes you happy, if that's what completes you, just don't let me see it. If I see it, share it with me. Right? That's how it is. It's going back to each and every individual happiness and, dignity and integrity. And that's what it should be. And nowadays, in reality, our healthcare is just, I don't know. Yeah.
Last question, at least for me, pot or Mary Jane. You see a lot of it?
So far, I've seen, the one that obviously that I see was just one, that individual with the MS guy. Other than that, they try to be very secretive, or even though it's legal, I tell them, yeah.
But he got better with that?
Yes, he got better with it.
Probably that, along with a lot of other things. I don't think marijuana is a cure-all for any particular disease, but unfortunately with marijuana, you just see too many young people taking advantage of the medical. You see the doctors looking for the handout to just come. We see at these medical dispensaries, 15-year-old skateboarders coming in and getting their marijuana, and it's because the doctor gives them a card because I have headaches. Who doesn't have headaches? You know what I mean? So yeah, and again, I don't want to get into the realm of the marijuana thing, but it does help some people. I'm not going to say it doesn't, but I think for the amount of people it helps, it hurts 1,000 times more. It hurts people 1,000 times more.
Yeah, in generalization, in reality, every ideas are good because if it works for you, that But then the thing is, a lot of the people out there, they don't need it and they abuse it.
Yeah.
And that's what it is.
More people than it helps.
And that's, and that's what I'm afraid of with this new legislature passed. How, am I going to be liable of a son that wants to speed things up for his dad? Where is that going to, see, that's why James and I, when we talk about it, it's more of a clinical and legal issues that's going to come back and hunt us.
So it would be nice for each individual to have an advance directive
Yes.
before fighting happen in the family.
Yes.
Absolutely.
So always be good to be ready
Yes.
before it happened. Because you know what? Don't you want to be heard what you wish? Right? Don't you want to be respected until that last dying breath?
I'm already teaching my kids that's what they need. I mean, I have a 21-year-old, and you never know when the man upstairs is going to pull your ticket. So it's like, he doesn't really have anything necessary. He doesn't have any kids or anything, but I have one, and it's laid out what, if my wife and I pass at the same time, the kids, what they have to do. It's a simple document that I think that's another topic that they're going to cover in these sessions. But it's very important to have that in place because we never know when our days come.
Yeah.
And it's better to be prepared than having all the families fighting and stuff like, not fighting necessarily, but just different opinions on things, that's all.
It's just, how we love, our loved ones are different. What we wish, but then they forget that, the most important part is that individual that's going through it. That's what I told my wife and my children. My children's 5 and 7. I told them, if daddy is not going to be able to play with you, please, I make sure that they know, that this is my wish. Because you never know. I'll be driving somewhere, you just never know. Every day is it's a time bomb.
Well, I know that you're saying that we are getting a lot older. I'm 83 and I feel very good.
Well, congratulations. You don't look like
But the whole thing is a lot of young men are dying. A lot.
Yes.
It's hard, either at 50, and they're in their 50s or 47 years old. I've seen so many this year that have passed away.
See, that's what I don't understand. Instead of focusing on Obamacare, again, going back to that, why can't we, do preventative care versus, it's too, the problem already exists. So why not, we'll prevent first and we'll deal with the problem. Now that we deal with the problem, then a lot of young people, I have my youngest patient in my experience was a 32-year-old. He started drinking alcohol at the age of 12 because he doesn't know any better, because that's how the family teaches him. See, again, as a parent myself, I want to start my kids young. Teach them prayer at 1-year-old. He knows Our Father at 1-year-old. That's how we need to go back to really, start them young, to start them early, realize them young. 32-year-old, that was the saddest thing, because that could be me. That could be, So.
Anybody else have any questions? We're good.
So I hope you guys get clarification what's palliative and hospice. Thank you. Thank you for your time.